Hi, good morning. In this presentation, I will tell you how to approach a spine case in exam, because it's a general discussion about a spine case, and the prototype we have taken today is a high cervical compressive myelopathy or a CV junction anomaly. So this patient can present in different ways. We'll just discuss it one by one. What is the presentation? What is the how to come at a clinical diagnosis and sort of things. Yeah, I have a call to attend. Just a minute.
Yes.
हाँ sir. Yeah. So the am I audible? Hello.
हाँ जी सर, हाँ जी सर.
ठीक है. So the prototype we'll be discussing is the CV junction anomaly. And what is most important in a spine case is actually this cross-sectional diagram and the ascending and the descending tracks and the topographic arrangement of the fibers in this cross-sectional anatomy. So as you can see, the lateral corticospinal track or the pyramidal track, the sacral fibers are the lateral, and the cervical fibers are the medial place. So any extradural compression or an extramedullary compression will first compress the sacral fibers, and that is why there is an ascending type of weakness in an extramedullary sort of compression. Contrary to that, I think I request everyone to mute. Yeah. So contrary to that, in the posterior column, the sacral fibers are the medial most and the cervical fibers are lateral. Similarly, in the lateral spinothalamic tract, the cervical fibers are medial, the sacral fibers are lateral. So in lateral corticospinal as well as the lateral spinothalamic, the sacral fibers are lateral and the cervical medial, and the posterior column, the cervical are lateral and the sacral are medial. The implication of each of this is like in an intramedullary pathology, when there is a syrinx or an intramedullary tumor, these cervical fibers are affected predominantly, the lateral corticospinal as well as the lateral spinothalamic. That is why the upper limbs are disproportionately involved compared to lower limbs in intramedullary pathology or a syringomyelia. So everything is related to this cross-section anatomy, And that is why you should know in this, in relation to this cross-sectional anatomy, where your lesion is lying. That's important. So many a times the examiner may ask you to draw this diagram and show in relation to this diagram where your lesion is lying, whether it's an intramedullary, extradural, or an extramedullary lesion. Other tracts are important, but the most important are obviously the posterior column, the lateral corticospinal, and the lateral spinal thalamic. Then coming to the chief complaints, which is usually the first thing which we start, though we start with the occupation of the patient, the his literacy and the reliability of history all should be mentioned. But the primary complaints which a patient of CV junction anomaly usually present are the neck pain, weakness of all four limbs, which may start from the lower limb, as you know that the sacral fibers are the peripheral fibers. Then gait instability due to spasticity. There can be sensory abnormalities. Less commonly, the patient may present with drop attacks, neck tilt, or neck clicks. So these are 4-5 cardinal symptoms which a patient of CV junction anomaly usually present. And this is a landmark paper by Wadia in 1983, which also says the similar thing, that the nuchal pain, drop attacks, progressive weakness in limbs, and gait instability. These are the usual presentation of a CV junction anomaly, and rarely it can be asymptomatic and diagnosed on routine MRI. So after the chief complaints, so chief complaints are the complaints told to you by the patient, and that should be mentioned in chronological order. Then coming to the history of presenting illness, any complaint, if it's a neck pain, if it's a weakness, if it's a sensory, it has to be described under the following headings. So the onset, duration, progression, aggravating and relieving factors, current status, and current disability. So for each complaint, that if it is neck pain, it was acute onset following trauma for since so long, and it is gradually worsening. It may be decreasing with application of collar or using analgesic, or aggravating wet movement. Because of this pain, patient cannot sleep peacefully, and he's very much disabled because the pain is constant, something like that. So this has to be a paragraph of each complaint incorporating all these points: onset, duration, progression, aggravating, relieving factor, current status, current disability. Will give a fair clue to the examiner that how to approach a case. So you are also not just concerned about when it all started, but you are also concerned about his current status as well as current disability. So that should be the norm in every complaint. Then regarding pain has some typical questions to be asked, like onset, duration, progression, nature of pain, whether it's a dull aching, it's sharp shooting, radicular, radiation, if any, if it is radiating to a particular dermatome. Are there any aggravating or relieving factors? Aggravating factors in case of CV junction nuchal pain is usually a cough-induced headache if it is associated with Chiari malformation. If the patient also has hydrocephalus, he can have the symptom of raised ICP, like early morning vomitings and all those things. Then diurnal variation should be asked for pain, because sometimes the pain of maybe TB spine or something aggravates during the night. That is called as the night cries. So these are the relevant questions to be asked for pain. And if it is associated with vomiting, it may give a clue that the patient may also have a raised ICP. Then weakness has to be, again, same pattern: onset, duration, progression. But regarding progression, you should be able to tell by history whether it's an ascending or a descending weakness, whether it's a symmetrical or asymmetrical weakness, or is it involving the proximal or a distal muscle group? What about the trunk and the neck muscles? Because we tend to tell about lower limbs as well as upper limb, but forget the trunk muscles as well as the thoracic muscles as well as the neck muscles. And these are all important in the CV junction case, because they may also be involved in the same chronological order as the fibers are getting compressed. So you should definitely tell about this trunk neck muscle as well as weakness of the respiratory muscle. Then obviously if it is a spastic weakness or flaccid weakness, is important to know the above upper motor neuron or lower motor neuron type. Inverted U-shaped pattern or Alzheimer's phenomenon is again is due to this topographical arrangement of the fibers, that the sacral are involved first, so lower limb followed by upper limb followed by contralateral upper limb, and then the contralateral lower limb. So this is again gives you an idea about if it's an extramedullary compression or a extradural compression. If there is some aberrant pattern, then you should be able to explain it, and it can be explained by the decussation of the fibers. At times in the lower part of the medulla, the decussation of the pyramidal tract happens, and if the compression is absolutely at the level of decussation, then there can be some aberrant findings which can be explained. So maybe a lower limb first and a contralateral upper limb next can also be presented, but can be a presenting symptom. But then you should be able to explain it with the anatomical knowledge. Then any case of spine, you should also always ask for a lower motor neuron sign at the level of your compression, because upper motor neuron sign will be present below the level of the lesion, but at the level of the lesion there will be lower motor neuron sign, and that will give you a clue about the exact level. The lower motor neuron sign will give you a clue to the exact level. Imagine there is a C5 C6 disc, then at the below this disc level, maybe C7 onward, there will be upper motor neuron sign, but at the level of C5 C6 your biceps may be depressed. There can be a focal fasciculation in the deltoid or something. Then that gives you a clue that your vertical level is actually C5 C6 and not the C3 C4 or C7 and C8, because there are upper motor neuron sign at C7 C8, but there is definitely a lower motor neuron sign at C5 C6. So that gives you a clue about your vertical level. Again, this diagram has to be always thought of during any symptom and where it is your lesion lies. Then instability of gait, there are two components to this. The ataxia can, in a spine case, can either be a sensory ataxia, which is due to the posterior column, and a cerebellar ataxia in case there is carry malformation and cerebellum is also involved. So it is important to ask history of wash basin ataxia. Wash basin ataxia is happens when the patient goes to the washroom, and in front of the basin he just puts water over his mouth. At that time he closes his eye, then he suddenly gets unstable. So that is because the visual compensation which is happening is temporarily halted because of closing his eyes, and then he gets ataxic. So visual compensation, whenever it's gone, a patient of sensory ataxia will be manifest with ataxia. So that is important, wash basin ataxia. Then disproportionate increase in dark, again, is because of the visual compensation, which is decrease in the dark. And obviously, if it's a cerebral ataxia, there will be other cerebellar signs like nystagmus, scanning speech, dysarthria, dysmetria, finger nose test will show maybe intention tremors, fast pointing. All these things should be known. Rudra, you may have to read that because the cerebellar system is also at times involved in a CV junction anomaly.
Yes.
Then the sensory complaints are usually difficult to, the patient is also not very cooperative and they tend to disregard sensory complaint. So either it can be a dorsal column, a spinothalamic, or a spinal tract of trigeminal nerve in case of a CV junction, because the spinal tract of trigeminal can go up to C5 level. So you should always ask for the symptom pain and temperature for spinothalamic. Ask for any difference in perception of temperature of water while bathing, any area of numbness. Posterior column, is again wash basin ataxia, feeling of walking on cotton wool. Cotton wool sensation is an important pointer towards a dorsal column involvement. And for spinal tract of trigeminal, obviously the same pain temperature over the face area, the onion peeling of sensation, all has to be asked. And it's important you also know the nucleus of trigeminal nerve, the motor, sensory, the spinal tract, the mesencephalic. At times, all this can be asked in case you are performing exceedingly well. Then, after this chief complaints, which the patient has already narrated, then you should ask some complaints which are not explicitly told by the patient, but which are relevant. So, are there any complication because of the lesion you are expecting, like a syringomyelia or a bladder ball involvement or a hydrocephalus? Then you should ask the relevant history. If there is a frequency, if there is urgency, there is incontinence, is there any features of raised ICP? And is there are skip areas in sensory loss, sudden anesthesia, all these things, because other than just extradural compression, there can at times a mixture of picture, like there can be a syringomyelia with a bony compression. So the picture in that case will be overlapping of an intramedullary pathology as well as an extramedullary pathology. And then that can complicate things. So you should be able to come out to a clinical diagnosis, analyzing all the factors. Then bladder is an important thing, mainly the upper motor neuron or the lower motor neuron bladder. So frequency, urgency, urgent incontinence is upper motor neuron bladder, and overflow incontinence is actually and lower motor neuron bladder. So this is broad, but there are other types like spastic bladder, atonic bladder, all those. You should know all types of bladder, because bladder is difficult concept to understand unless you read it frequently, and you should be able to correlate your bladder findings with the pathology you have. So again, in a CV junction, usually it's an upper motor neuron bladder, so you should know all the features of an upper motor neuron bladder. And if it's a conus cauda type of picture, then it can be a lower motor neuron bladder, which also you should know. And again, syring we already discussed, and raised ICP also. This is the positive part of history, other than the what we discuss is the bladder bowel, the raised ICP, carry malformation. All these are positive parts of history which are to elicit. There are also important negative history to be asked, so that you come at a clinical diagnosis and the examiner gets a clue that you are actually know how to narrow down your diagnosis. So the history of cranial nerves that can get involved in a spine case, right from second nerve, because of hydrocephalus and optic atrophy. Fifth nerve, as we already discussed. Sixth nerve again is because of the raised ICP. Eighth nerve is very commonly found in sensory neural hearing loss, is found in CV junction anomaly. Then lower cranial nerves 9 to 12 can definitely get involved. Then history of etiology, like tuberculosis, which is an important cause of any spine pathology in India, right from CV junction, TB, pot spine, subaxial spine, everything. Intramedullary tuberculosis is also reported. So all this has to be asked. Then history of any case, you should always ask for what etiology are you suspecting, whether it's a trauma, infection, congenital, or neoplastic. So that should be asked. Trauma, history of any infection, cough, fever, hemoptysis. Congenital, if it's present since birth, or developmental, is there a neoplastic like anorexia, loss of weight, in addition to whatever you're asking? This has to be asked for history of etiology. That can give you a clue to the etiology of your problem. And in CV junction particularly, it's important to ask for syndromic CV anomalies, because many syndromes, over 100, are associated with CV junction. and you should definitely know some of them like Klippel-Feil, Down syndrome, Marfan syndrome. So you should know what symptoms will be there in such cases. We have many cases which come with Marfan's, and unless we know what symptom and sign to look for, we may miss. Then this etiology, I already discussed. Congenital will be an early age of involvement. Usually it's syndromic with other dysmorphic features. Trauma can have a definite trauma, history of trauma, infection. There will be constitutional symptoms of infection, severe nuchal pain. Tumor, again, we are discussed like weight loss, emaciation, and the age will be further higher compared to congenital or developmental cases. Then after all these things, you have asked you have covered the chief complaints in the order which I told you. Then you ask important supportive history of complication like bladder, bowel, hydrocephalus, etc. Then you have also ruled out some pathologies by a negative history. Then you have asked for history of etiology also. So now you are narrowing down. You have started with a vague complaint. You have described that complaint. You came to know that it is something like an extradural extramedullary pathology. Then you narrowed down further that there are no complicating factors like syringomyelia, carry malformation. Then you came to etiology. Then you found out that it's a congenital problem or a developmental problem because it started very early in life. Then again, you are narrowing down, and you have to finally come to what are the current functional disability because of this problem, and then summarize your history. So you have to tell for upper limb, you is not able to feed himself. There is difficulty in buttoning, unbuttoning. For lower limb, the ability to walk independently, or there is problem with activities of daily living. Bladder, bowel symptoms, if any. These are the problems which the patient will have. Then this is regarding the present history. Then you come to the past history standard, any history of surgical procedure, TB, personal history, family history for syndromes, and treatment history. This has to be finished as a part of protocol. Many a times it may not give you any additional information except for syndromic cases, as well as a past history of TB may also be important, or TB history in family may also be important, from which the patient may have got the infection. So till this time, the examiner, it's almost 20-25 minutes you are uttering. The examiner doesn't usually stop you in between. So then when you say that summarizing my history, then they suddenly wake up that now they will give due attention to each and every word which you are talking. And that is why it's very important that your summary should be crisp and should give the examiner an idea of whatever has been told in the last 30 minutes in a simple, easy to understand, and in a language, in a paragraph, which will be self-explanatory. So you have to start like that my 30-year-old patient presented with 6-month history of neck pain, 4-month history of gradually ascending progressive spastic quadriparesis, which involved the right lower limb first, then the upper limb, then the left upper limb and lower limb in a particular pattern, associated with sensory complaints, pain, touch, and temperature. Sort of like you should be explaining along with lower motor neuron sign at a particular level. Whatever has to be told in a one para, and it should be a smooth flow. You should also tell that there is no you can tell important negative history also. I'll tell you the para exactly how it can be done. Then nature of lesion. By this it's an extradural or intradural lesion, whether it's a vertical level of the lesion and the horizontal. The horizontal will be this extradural, intradural, or intramedullary, and vertical will be the exact vertical level, that it's a craniovertebral junction or a C2 or a C5 pathology, complications and etiology, which we have already asked. This has to be all come in summary. And cardinal signs and symptoms you all know. For extradural, it's pain, tenderness, deformity. For intradural, extramedullary, it will be a brown sickle-like syndrome. For intramedullary, dysesthetic pain, early bladder ball involvement, upper limbs are more involved and lower limb, descending weakness. So you know, and on this premise, you have to diagnose your case. So this chart is important. You know that extramedullary will be asymmetrical, intramedullary will be symmetrical. All these points you already know, but just it's important to you apply this knowledge there. So that is why each question we have asked before is important, whether it's a unilateral, asymmetric, symmetric, ascending, descending, autonomic involvement, early, late, everything is important. So the clinical diagnosis should include whether it's a myelopathy, a radiculopathy, or myeloradiculopathy. So high cervical or low cervical. High cervical is usually above C5 and low cervical is below C5. What is meant by high cervical above C5 is again very vague. Then you have to narrow down to whether it's CV junction or C2 or C3 or C4 by the lower motor neuron sign. Like regarding C3, C4, you can ask for trapezius, sternocleidomastoid. Regarding C2, you should ask for a C2 neuralgia or numbness in the nape of the neck. Then patient cannot feel the pillow because of the numbness on the nape of the neck. All these factors will point towards narrow down your high cervical layer further to a myotome. So it's important. Then horizontal, we already discussed complication, bladder bowel, ICP, syringomyelia, and probable diagnosis. So what is usually is asked is you summarize your history, then they will say, then what is your diagnosis, or tell us the substrates involved. So you will say that I feel it's a extradural compression, probably a bony CV junction anomaly without any syringomyelia, without any hydrocephalus, and CV junction is my diagnosis. Then they can ask why CV junction and why not C3, C4. Then you can say that there is numbness of nape of neck, there is lower cranial nerve involvement, all those things. So then you have to be justifying whatever you are saying. So only talk those things which you can justify and try to arrive at a diagnosis based on the history by gradually taking out points against and gathering more points in favor of a particular diagnosis. Then the next question is the anatomical structures involved, which then you can tell that bilateral lateral corticospinal, bilateral posterior column, bilateral spinothalamic are involved. Autonomic fibers may also be involved if there is bladder involvement. All these things has to be told depending on the history. If there is lower cranial nerve involvement, then you can also say about the lower cranial nerve. So this is usually the clinical history, and this will decide whether you fail or pass, because many a times it may happen that there can be a mixture of picture, like there is extradural compression as well as there is a syringomyelia, and then it's a bit of confusing picture. Just a minute. Hello. अच्छा ठीक। ये नया टीम पे तुमने माइग्रेट किया, वो चलता नहीं यार, क्या है अभी? अरे वो छोड़ो, वो पुराना जो चल रहा था उसको क्यों नहीं कर रहे हैं? अब तो मीट चलने दो ना। अब तक बताओ, any question till now? हेलो,
हाँ।
सो तो नहीं गए सब?
नो सर,
नो सर।
तो अभी तक कुछ समझ में आया? ऐसे ही करते थे तुम लोग कि कुछ अलग तरीके से प्रेजेंट करते थे, क्या था?
सर इतना स्ट्रक्चर्ड नहीं रहता था हम लोग का, मतलब बहुत स्ट्रक्चर्ड है सर हम लोगों को। वो इसकी रिकॉर्डिंग या फिर इसका या वो चाहिए, वो रहेगा तो
हाँ,
सर
रिकॉर्ड कर
भी
रहा हूँ
हेल्पफुल।
मैं, वो अगर हो जाता तो मैं शेयर कर दूँ।
जी।
So, any question till now? Is there any confusion, Rudra, in your mind? How you have to progress? This is a prototype. CV junction is the most complex case which you can get. Otherwise, you will always get a simpler case than that. Because if it's a mid dorsal spine, again the same has to be applied, like extradural, extramedullary, intramedullary, and the complexity will go down because there are no lower cranial nerves. There are no spinal tract of trigeminal. No, lot many things are automatically filtered out below CV junction. So it will be far
So,
easier if it's a lower one. But the concept will remain.
lot of times,
Yeah, tell me.
so lot of times it's that extradural doesn't come with the exact ascending pattern. Especially the hands involved first.
आवाज तुम्हारा ना बहुत ब्रेक हो रहा था, फिर से बोलो।
हाँ sir, that ascending pattern always doesn't come clearly by taking the history.
Exactly, but
This is the only.
no, actually, obviously diseases don't read books, but if you take out a proper history, there can be subtle things which are usually the patient misses in chief company. So if it's you will get some history which will point that there will be a proper pattern. And the other frequent cause of not getting a typical pattern is actually a syringomyelia, which is associated, or a cord signal change at that level, which is actually conflicting the straightforward picture. So if there is an aberrant pattern, always think about syringomyelia. Syringomyelia, if it is there, it can complicate all standard presentation. And then it's a good excuse to say that it's a syringomyelia in association with an CV junction anomaly. If you can just keep it.
Sometimes there is an ascending pattern just preceded by just hand numbness and ascending pattern.
No, again, tell me, your voice is breaking.
Yes, can you hear me?
Yeah, I can hear you. Yeah.
Sometimes the patient just starts with the hand involvement after that ascending pattern.
नहीं, तुम ना चैट बॉक्स में टाइप कर दो, विल टेक दैट, बिकॉज तुम्हारा आवाज बिल्कुल क्लियर नहीं है, ठीक है ना? गौरव, तुम्हें समझ में आ गया होगा तो तुम पूछ लो उसके बिहाफ पे।
नहीं सर, सब जगह ब्रेक हो रही है।
सब जगह ब्रेक हो रही है सर।
एग्जैक्टली, तो वो आवाज नहीं आ रहा है समझ में, तो टाइप कर लो इन केस नेटवर्क इशू होगा तो। सो Gaurav, Hitesh, you have any question or it's okay, we can move ahead?
So we can go.
नहीं सर, ओके सर।
ठीक है। So coming to the general physical examination in a spine case, many a times we forget this important portion of in spine case, and that is right from the general condition, syndromic phenotypes like short neck, neck height ratio, low hairline, all these are important in CV junction. Neck height ratio, you already know that 1:11 to 1:14. Then low hairline, it's below C4. Autonomic function like postural hypotension, if the patient has subtle autonomic dysfunction, then that may present with a postural hypotension. So there may not be any manifest bladder ball involvement or something, but there can be a subtle postural hypotension, which can be a presenting feature of a autonomic dysfunction. Then features of neurofibromatosis, because many a times CV junction pathology can be there due to a neurofibromatosis, foramen magnum, something like that. That can also present like a CV junction anomaly. You should always ask that. Then respiratory system is important, single breath count, breath holding time. In cardiovascular system, it's relevant if it's a marfanoid habitus, you should always see for any murmur, because aortic regurgitation is a common feature in Marfan syndrome. Then in physical examination in spine case, you should always talk about the stance or gait of the patient when you examined him, how it is walking, whether it's the gait is spastic, scissoring gait, antalgic gait, whatever gait is there. Obviously, it will be most likely a spastic gait because of the compression of the corticospinal tract. So these all factors are important, and if you tell that right at the beginning of your examination, that gives a very good impression that you know what is relevant to this particular case. Then syndromic CV junction, it is important to rule out common syndromic association, Marfan syndrome, Klippel-Feil syndrome. Klippel-Feil is webbing of neck, low airline, short neck. This has all even has to be asked even in history, whether there is, and also has to be checked in examination. Marfan syndrome, the arachnodactyly, the ligament laxity, the arm span to height ratio, and this, you just revise all these criteria which is used to diagnose Marfan syndrome. So the purpose of examination is again to highlight to you about the generally physical examination points and the syndromic points. And Down syndrome also, if the patient is a case of Down syndrome, then you should know what else to check: the simian crease, the interdigital. There are, I think, simian creases there. There can be a low set ears. बहुत सारे हैं उसमें features. You should know that at times people have examiner have an uncanny habit to, even if it's not a Down syndrome, they will ask you what features will you look for in Down syndrome. And then that is why you should also know what percentage of Down syndrome have CV junction anomaly, what percentage of Down syndrome usually has AAD, and why, what is the cause. So this can be a parallel discussion. And common syndrome, Klippel-Feil, Marfan, and Downs, you should know thoroughly what are the problems, how it is diagnosed, how it is managed. Okay, what are the special consideration for managing such cases? Then the neurological examination again proceeds in the usual way. Try to be systematic, start from the higher mental function, though it may be completely normal, but don't directly jump to power 3/5, power 4/5. ये सब नहीं करना है. You have to be in a systematic way. Higher mental functions, patient is conscious oriented, his mini mental score examination is so and so, grossly normal. Cranial nerves start from 1 to 12, because I already told you that even in spine case, many cranial nerves can get involved, and you should just tell that it has been checked. And see, even if you can see fundus in a CV junction case, and even if you tell it's normal, that gives a very good impression that you know why it has to be checked in a spine case. So there may be hydrocephalus or something, and then you can justify. So these are all scoring points that will give the examiner an idea that this candidate knows everything which is related to the case. Then comes the motor examination. Motor examination, again, tone bulk is important. Don't directly jump to power. Then the reflexes, superficial, deep, and plantar, everything. Then sensory and cerebellar. Cerebellar is also important. There are various signs in cerebellar examination which has to be read, right from the finger nose test, the dysdiadochokinesia, the past pointing, nystagmus. At least 7-8 signs you should be able to tell the examiner if he asks. It means and where you can actually falter if you do not read them. Motor, I already told you. Sensory, you should have a proper kit to test fine touch, crude touch, pain, temperature, joint position, vibration. These are all the problems. If you do not have, just do not prick with anything. You should have proper thing like the cotton, then how to touch, crude touch with the we usually use the blunt end of the needle for crude touch, then pain temperature, have proper temperature. You should at least know the temperature which is used for testing cold as well as in hot sensation. Then joint position, vibration also. Any tuning fork doesn't work for vibration. There is a particular frequency. For hearing testing, there is a particular frequency. You should have everything in kit and should compare with normal areas simultaneously. And lastly, this local spine examination is also important, and you should comment on the curvature, deformity, tenderness, everything at the end. So final summary has to include if examination has added some additional things to your diagnosis, and they will ask is what is your final diagnosis after this examination. So examination, usually they do not stretch you much. They will usually have made their mind by then that your approach to reach a diagnosis was good on history. So probably you know. So many a times, even if your clinical diagnosis is wrong, but if your approach is correct, that's also okay. So it may happen that you diagnose it as an extradural compression and it turns out to be an intradural extramedullary. Or but if you are able to justify whatever has been told by the patient, then it's okay. Means in the sense, you know, it may not actually be absolutely a perfect diagnosis. That is why those make perfect diagnosis are usually seen with a lot of doubt, because then that means many a times that they are not able to justify the history, but they say that the diagnosis is यही है सर. यही है सर का मतलब यही होता है कि MRI आपने पहले ही देख लिया एंड फिर आप उसमें फिट कर रहे हो, और फिट करने में हमेशा प्रॉब्लम होते हैं क्योंकि your knowledge and justification doesn't go hand in hand, and then there are problems. Then they put another counter question which makes you feel in a trap, and then you are trapped from everywhere. So never see the MRI, never ask any MRI findings. By and large, if you are okay, that's okay. Means if your level goes down by one level higher, it's instead of C5 you diagnose C6, that's okay. Instead of extradural you direct intradural extramedullary, that's also okay, till the time it is justifiable by your history and examination. Okay, then MRI may actually turn out to be something different. This is particularly true. This has happened with me in my MCH exam. I had probably diagnosed it as an intramedullary lesion, and it turned out to be an intradural extramedullary lesion. But the patient also has syrinx, and the symptoms were overpowering of syrinx rather than an intradural extramedullary compression. So I diagnosed it as an intramedullary pathology, and when the MRI was shown, it was an intradural extramedullary pathology with syringomyelia. So the examiner said that that's okay because the approach, your approach was good, and you could justify whatever has been means even with clinical diagnosis, we had made the same diagnosis. So it may happen. So don't see MRI. Never even during exam, before exam, anytime you're practicing, try to make your own diagnosis. Then how will you manage will be the next question, and the management doesn't need surgery as the first answer. So you will always tell that I'll do such and such investigation. like X-ray करेंगे, dynamic X-ray, CT scan, MRI, CT angio. Then they can ask any this McRae's, McGregor lines and all those things. What surgery? What are advantages of anterior, posterior, steps, complication? These are all then theoretical discussion. So this is what I wish to tell you, that be logical, follow a particular pattern for each symptom, reach at a clinical diagnosis by analyzing all the factors, try to take out factors which you feel are lacking to make a clinical diagnosis. So at times you feel that there should have been an involvement of the upper limb first, then you ask particularly. Many a times small things may be missed by the patient. Don't forget trunk muscle, neck muscle weakness, difficulty in completing sentences is an important feature of an respiratory muscle involvement. And all these are actually has to be taken out smartly from the patient, and then analyze it. Also ask for important negative history, etiology history, summarize in one paragraph in a self-explanatory way. Then always remember that cross-sectional diagram. Always remember the syndromes which may be associated, and hopefully then you will succeed. Okay, any question? Any question?
नहीं सर.
Type one in the chat box.
So hand involvement followed by ascending pattern. So it can be again, this can happen because many a times even an extradural compression can have hand involvement because of the venous congestion at a particular level. So you should see the dominant pattern, and in that case also you can say that it can be an ascending weakness, but you should be able to justify. Then they will ask why then hand weakness first. So then you can say that there can be a lot of times there can be venous congestion because of the compression, and even at a higher level there can be problem because of that. So it's not an issue. See the dominant pattern. Again, syrinx is important. Syrinx you should always think about if there is any aberrant problem for syringomyelia. In CV junction cases, this is a very frequently asked question, that CV junction compression at a higher level, but there can be some, like you already told, hand involvement. Because of usually venous congestion, there is a distally there is a problem with conduction of impulses, and there can be of hand weakness or grip weakness to start with because of that, and it is justified. It can be justified by anatomical knowledge. So anything which can be justified, it's okay. और रुद्रा, और तुम्हें और कोई डाउट? Gaurav, Hitesh, any doubt?
नहीं सर.
So Manoj, do you wish to add something?
No, sir.
Dr. Manoj, do you wish to add something?
No, I'm fine.
Okay.
Hello?
Yeah.
Yeah, this is fine.
Okay. ठीक है रुद्रा, फिर that's okay. So all the best for your exam. Just follow this pattern. And short case is usually the chief complaints followed by a clinical diagnosis. So you do not have to explain everything. You just tell the chief complaints. You may take a short history of present illness, but that is usually not to be told. You just have to tell the chief complaints, and then they will directly ask you a diagnosis. But the pattern will be the same even for a short case. The same pattern. You come always in life follow this pattern, and you will not miss a clinical diagnosis. And then usually the discussion in short cases is on the management of that cases rather than the clinical diagnosis. So with chief complaint like swelling in the back with lower limb weakness, something like that, then your diagnosis is probably a spinal dystrophism, open spinal dystrophism, most likely a meningomyelocele. Then they will ask you the meningomyelocele management. Okay, something like that.
Yes.
ठीक है? Should we close this now?
Okay.
Okay, good.
Okay.
ये
Yes, sir.
recording हो जाएगा तो I'll send.
Thank you, sir.
Okay, thank you.